Hi, I'm Dr. Dara Rampersad of Blue Paths First Responder Services. I'm a first responder psychologist that's based in Phoenix, Arizona, in the US. And I'd like to say thank you for having me today. It's such an honor to present at the ACOP conference to such esteemed colleagues. What I wanted to chat with you about today was some of the US based issues that are taking place that are also, I'm sure, quite global that you could relate to. But we're going to focus on post traumatic stress issues, suicidality, grief, and then resiliency and officer wellness, or first responder wellness in general. The first responder populations that I'll most commonly be referring to will be law enforcement, fire. We'll also have correctional officers, dispatch call takers, EMS workers, ambulance workers, and then we'll have hospital-based clinicians as well that provide emergency services care. So as we delve into this, I want to start with post-traumatic stress. A lot of the common complaints that I hear from the patients that we treat are complaints around administrative issues. Many first responders report that they could do their job all day long, as they would say, if it weren't for the administration and the administrative stress that they experience on their jobs. We saw this exponentially increase since COVID occurred, and the calls for service really changed in a lot of ways for what mandatory responses would be to certain calls. And for certain calls, there were no responses that were given to the community. We also had an increase in stress related to political strife that took place here within the US on January 6th of last year. There was also this direct relationship to Black Lives Matter protests that were taking place globally, as you would have seen. Here in the US, it really affected a lot of white or Caucasian police officers because they were feeling unsupported by their administration if they needed to go hands-on with somebody of color. And so as a result of it, we've seen more hesitancy. In fact, one of my clients not too long ago, a couple of months ago, was telling me about his restraint in going hands-on with somebody who was a person of color. And he felt like he hesitated so long, it ended up causing him injury to his shoulder and his back. But he was in retrospect, feeling like he hesitated too long with this person to take him into custody. These are typical types of conversations that I have now compared to before. And it's a very tough environment for policing in general right now because of these types of incidents that have occurred over the past couple of years. So that is a huge aspect, is administrative stress that's taking place on the first responder. But then we also have obviously situational types of things, typical calls that first responders get dispatched to that are beyond their control. One of my colleagues refers to this as PTS by 1,000 cuts. Is not getting involved in an officer-involved shooting, is not getting involved in a major, sort of event as a firefighter or correctional officer, or riot, or some sort of hurricane response or FEMA response. It actually is just these typical run-of-the-mill calls that are dead baby calls, juvenile calls of any kind, running on suicides and homicides, and just senseless death. As one of my people had stated, he says, "I'm sick and tired of all of the carnage that I've seen, and I just don't want to see it anymore." And in that light of things, we're seeing people like him and others who are looking towards early retirements, sometimes medical retirements, and sometimes natural retirements. But I've also seen an increase over the past few years of people who are reaching 5 to 7 to 10 years who are deciding that they no longer want to stay in this profession and they move on from it because of the amount of stress that they've experienced over the last few years of providing services. And this has caused a lot of stress on people who have stayed in the positions because now they have mandatory overtime that's causing them stress and is pulling them away from their families and other primary support systems or activities that they would do. And we have those people who are coping utilizing skills that may not be very productive for their relationships or for their well-being. And as a result of it, they are going further and further down a slippery slope of poor coping mechanisms. Um, Commonly, of course, is infidelity in this population, in the first responder population. Some people might refer to it as being trauma bonding between partners on a job. And so intimacy is built up inappropriately, and then unfortunately the relationship carries on further than the either person had intended until it ends up in a compromise. And then relationships fall apart, both at work as well as at the home. We see an incidence with people who are bringing stress from work home and stress from home to work. And it has just increased a lot over the past few years that we've seen in treatment. On the risk factor things for suicidality, tied into financial relationship instability, maybe addictions that are taking place with alcohol or pain medications, administrative issues at work where people are being investigated, and sometimes that stress is really too much for them to bear. Maybe they have picked up driving while under the influence, or they've had other issues that they've been investigated for. Sometimes we see this spillover into this risk of suicide increase. And unfortunately, we need to look at some of these things in a posthumous way to determine forensically why this person died. And I will tell you that in a majority of the cases that I have seen with suicide, of course, we have our typical perceived sense of burdensomeness, lack of connection or connectivity. We have people who feel like they can't relate to others and they isolate themselves. But that's typical within the first responder population anyway. But we're talking about an increased level of that. And then we also see lack of sleep. And the lack of sleep is really, as I go through so many cases of people who have died, unfortunately, this lack of sleep has been taking place for days at a time. The person has started to have some hallucinations or delusions. And sometimes we even see this misdiagnosed as bipolar disorder, where the person may come off as being manic for why they're staying awake for so many days. But in itself, that feeds misdiagnosis where we're losing post-traumatic stress as being the primary issue, and chasing bipolar disorder as being the primary diagnosis. I'd like to make sure that clinicians who treat first responders are aware of this. Is this misperception that it could be a bipolar illness when we are ignoring the post-traumatic issues going on or stress issues going on. And to attend to those post-traumatic stress issues, there is a reason that that first responder is deciding not to go to sleep. Typically, it's related to nightmares where they don't want to engage in dream sequences that are nightmares. And so they avoid it completely, or they try to self-medicate with alcohol or other things to be able to try to get down to sleep. Unfortunately, of course, as you would guess, the alcohol stops working after a while to help you sleep, and you end up waking up at odd hours of the morning and then needing to drink more to get back to sleep. We also see where people get addicted to pain pills because of injuries on a job, opioids and other things, that sometimes when those prescriptions run out, they seek drugs from the street to be able to take care of that need. So they end up getting fired, losing their professions, but also their careers and their livelihood as a result of it, unfortunately. So with those factors, looking at those risk factors tied into some of those other ones that I mentioned, we have that increased risk of suicidality. It's important for us to look at the totality of the circumstances, as it also includes other risk factors, such as people close to them who have died by suicide, history of engagement in suicidal ideation or behavior previously. And then I found for myself, the most effective way for me to be with someone who is suicidal is for me to be non-judgmental and to listen to the suicidal risk stories that people are telling me. I don't act on things impulsively and try to hospitalize everybody who says that they're suicidal. I want to understand what suicide will do for that person, and then also to figure out things that they are ambivalent about. And so, how could we focus more on the ambivalence piece versus the commitment piece towards the act? And once we start to have a well-rounded conversation, and I really do mean this, there is nothing that I could do, and I tell them this, to prevent them from killing themselves, because they are an adult and they can make that choice. What I do engage them to do is to give me 6 months. I always ask for 6 months. That's my magic number. And I tell them, work with me for 6 months, and things will change, luckily, knock on wood, things work that way, where time tends to really change things around for that person, and things get better. So always buy time. It's important to ask for time and just keep pushing for that time. Sometimes the person may not be ready to commit to it, and that's when you have to look at other options available to you in your communities. Um, let's talk about grief. Grief is obviously permeated throughout the first responder culture and world because of the types of calls that they get dispatched to. So be aware as a first responder of your own grief as you go to these types of calls that you could relate to and that are sticky to you. They stick with you. You can't get them off your mind. I had a firefighter refer to himself as having air brake amnesia. And I asked him, I said, what is air brake amnesia? He said, that's the sound that the brakes make on a truck when I get back to the station. And as soon as those air brakes go off, I forget the calls that I went on. And I thought to myself, wow, what a brilliant way to really practice resiliency, is pushing those calls back and just looking forward to the next calls that you have to go on. The other aspects of resiliency that I'd like to focus on now would include things like peer support training, as well as peer support implementation. Now, so that's people that have this profession that are also supporting other people within the profession. I also see a really positive shift right now in departments preemptively towards wellness checks. We provide a lot of wellness checks for different departments, and sometimes they're on quarterly, biannual, or annual basis, depending on which specialty units they belong to. And this has been a really positive experience for all of the first responders that come for them, because they're no longer stigmatized by having to come in for a wellness check or for treatment. They are allowed to come in, they're allowed to dump whatever they've been carrying with them. And that we really decrease the stigma of treatment and care as a result of it. So I'm a big proponent of that piece of resiliency and wellness. Mindfulness training, meditation is really helpful to be able to slow things down and to get back in touch with where you are right now. Spending time and quality time with your family, or engagement in the things and activities that you usually enjoy. Journaling is very good because it engages many parts of your brain to be able to get out things that are on your mind. Of course, I'm biased to therapy. I think that therapy is also very positive for a lot of people as they build their resiliency. And then I try to tell people to engage in fun. This last Christmas, we bought a table tennis board for us to be able to play as a family. I haven't owned one since I was a child, so it's kind of going back to childhood and getting things that are fun, that you could actually just have fun doing. Going easy on yourself and not being too critical, self-critical, is important. Separate stresses out so that way they don't get balled up into one big ball. It's important for that, for anxiety and depression specifically as well. And then talking with others about stresses. It could be a clergy person, a friend, someone who you trust. Is important to be able to share that burden. And keeping a routine, getting to bed around the same time, waking up around the same time, exercising, eating, etc., is all important for the first responders to pay attention to. And I also like to really encourage them to travel and to get out of their own headspace, to see something new and be open to new experiences, because I think that helps to open up a worldview that provides more stability for them. Well, hopefully this snapshot has been very helpful, and I look forward to being able to engage with you again. Please feel free to reach out to me. The US code is 1, and then the area code is 602. My cell phone is 345-1425, or you could look up my website at www.bluepaz.com. Thank you very much for your time. Bye-bye.